Today, we're going to tackle two important allergy topics that often overlap in clinical practice: food allergy and latex allergy. Both of these can range from bothersome to life-threatening, and both require careful diagnosis, prevention, and patient education. Let's start with food allergy. A food allergy is an adverse immune reaction to certain foods. We divide these into IgE-mediated and non-IgE-mediated reactions. IgE-mediated reactions are what most people think of when they hear food allergy. They're immediate, potentially severe, and affect about 5% of adults. Interestingly, nearly 1 in 5 people believe they have a food allergy, but only about half of those have a true immune-mediated allergy. Almost any food protein can be the culprit. The most common adult triggers are fish and shellfish, things like shrimp, lobster, crab, clams, and finned fish, as well as peanuts and tree nuts like walnuts and cashews. Milk, eggs, soy, and wheat also make the list. One important point is cross-reactivity. Because allergens are proteins, foods with similar proteins can cause reactions even if they're technically different items. There's also something called oral allergy syndrome, or pollen food allergy syndrome. This happens in people with pollen allergies who develop itching or tingling of the mouth and throat when they eat raw fruits or vegetables. Cooking usually breaks down the proteins, so cooked versions are tolerated. Now, how do these patients present? The classic acute signs are hives and angioedema, swelling of the lips, mouth, tongue, and throat. Respiratory symptoms like cough, wheeze, and laryngeal edema are common, and GI symptoms such as abdominal cramping, nausea, vomiting, and diarrhea round out the picture. Peanut and tree nut reactions are the most likely to escalate into anaphylaxis. Diagnosis begins with a careful history and physical. We can use elimination diets and food diaries to narrow suspects, then confirm with skin prick testing or allergen-specific IgE blood testing. The gold standard is a supervised oral food challenge. For non-IgE food allergies, a 48-hour patch test may be useful. Management always starts with avoidance. But because strict avoidance isn't always possible, every patient with significant food allergy should carry an epinephrine autoinjector and know how to use it. Medications such as H1 antihistamines, corticosteroids, and adrenergic agents are used based on severity. Patient and family education is crucial. Label reading, recognizing early symptoms, navigating restaurants, and planning for emergencies. A newer option is oral immunotherapy, where patients ingest tiny, gradually increasing doses of the allergen under supervision. The goal isn't cure, but raising the threshold so that accidental exposures are less dangerous. Peanut, egg, and milk immunotherapy can desensitize many patients, though tolerance usually requires ongoing exposure. From a nursing standpoint, documentation and preparation are essential. Build an emergency action plan, make sure allergies are flagged in the record, and teach patients to always carry epinephrine. Now let's shift gears to latex allergy. Latex allergy is a reaction to proteins found in natural rubber latex from the Hevea tree. It has been linked to rhinitis, conjunctivitis, contact dermatitis, urticaria, asthma, and anaphylaxis. The prevalence is 4 to 7%, but has declined as healthcare facilities move toward powder-free and latex-free gloves. High-risk groups include healthcare workers, patients with multiple surgeries, and individuals with spina bifida, since they undergo repeated procedures and catheterizations. Other occupations like factory workers, hairdressers, food handlers, mechanics, and law enforcement can also be at risk because of frequent glove use. Here's an important pearl. Latex allergy often cross-reacts with certain fruits. Bananas, kiwis, avocados, chestnuts, and mangoes can all trigger symptoms in latex-sensitive patients. Exposure happens through the skin, mucous membranes, the bloodstream, or even inhalation of glove powder carrying latex proteins. And latex is everywhere, from gloves, catheters, and IV ports to balloons and household items. Thankfully, safe alternatives exist, such as nitrile, neoprene, and vinyl products, as well as guayule-derived rubber. Latex reactions fall into 3 categories. First, irritant contact dermatitis. This isn't an immune reaction. It's irritation from soaps, glove powder, or occlusion. It causes redness, itching, and chapped skin. Second, allergic contact dermatitis, a delayed type 1V hypersensitivity. Symptoms such as itching, vesicles, and crusting usually appear 18 to 24 hours after exposure, and while not life-threatening, they can be uncomfortable and persistent. The third and most serious is immediate type 1 IgE-mediated latex allergy. Within minutes of exposure, patients may develop rhinitis, conjunctivitis, urticaria, wheeze, laryngeal edema, or even full-blown anaphylaxis. Diagnosis combines history, physical exam, and specialized testing like skin or serum latex-specific IgE assays, or patch testing for suspected contact dermatitis. These should only be done by trained providers in settings equipped for emergencies. Management starts with strict avoidance and latex-safe environments. Patients must alert providers before any procedure and wear medical identification. Anyone at risk for anaphylaxis should carry an epinephrine auto-injector. In the hospital, supply chains need to provide clear latex-free alternatives. If a reaction occurs, type 1 cases are treated immediately with epinephrine, airway support, oxygen, fluids, vasopressors, and corticosteroids, with close observation for recurrence. For irritant or allergic contact dermatitis, management involves barrier protection, moisturizers, and switching glove types. Nurses are central to prevention and education. We must ask every patient about latex allergy, especially in high-risk units like OR, ICU, and the ED. Teaching patients to identify latex-containing products, choose alternatives, and recognize symptoms early is vital. So, in summary, both food allergy and latex allergy are immune-driven, potentially life-threatening conditions. Food allergy is usually IgE-mediated, with nuts and seafood as the most dangerous culprits. Latex allergy can present as irritant dermatitis, delayed hypersensitivity, or immediate IgE-mediated anaphylaxis. In both cases, the foundation of management is avoidance, preparedness, epinephrine, and education. That's it for today's lecture on food and latex allergy. Thanks for listening. This is Dr. Atkinson reminding you that knowledge, preparation, and patient teaching save lives.